Good morning and welcome to the second parallel session of the second day of HelpAge Asia Pacific Regional Conference. The session is entitled as Financial Implications of Different Policy Choices in the Context of National Health Systems Reforms. This is the second day of this conference, and one thing which we have been very clearly hearing since yesterday is the economic implications of aging in the context of cost on healthcare. So this is exactly what we are going to discuss in today's panel. It's my great pleasure to moderate the discussions. Let me introduce myself very briefly to you, and then in a few minutes I'll have the pleasure of introducing the panelists to you. So I am Prakash Tyagi, and I lead a non-governmental organization in India called Gravis, which is a HelpAge international affiliate and which has a number of programs with a strong focus on healthcare for older populations. What I have been hearing since yesterday and the discussions and some initial thoughts that come to my mind to set up the stage for these discussions. One is that we have clearly been hearing that the costs on healthcare are rising. We heard that this morning as well. The session which was in the morning with John Beer and Marianne Sau. These costs could be varying at a different level in different countries in the Asia Pacific region based on countries' capacities. But the costs are definitely rising and they are going only one way, which is more expensive in years to come with the demographic changes. We also have been discussing since yesterday, and it was pointed out in a ADB presentation very strongly, that although all Asian economies or most Asian economies are growing significantly in terms of their GDPs, but they have not been able to reduce the inequalities at the level which other regions have been able to do, like Latin America or the African region. So there is definitely this reality that lack of resources may not be the problem. It's how resources are being spent. That's where there is a problem. I also feel that when we talk about financial implications on how the resources are going to be spent on healthcare for older people, the human resource situation has an important element. We all know that the workforce is not adequate, and that situation also seems to be irreversible. We are probably not moving into a direction where we will have more human resources in terms of physicians, in terms of healthcare providers. So that's where we stand. Asia Pacific region is also a region which is very large, very diverse, and we just heard in the morning, some of you who were here in this room, that there are varying level of expenditures, beginning from countries like Japan on social protection, on social programs, all the way going down to countries like India and Pakistan and Bangladesh. So it's a country of, it's a region of a lot of diversities, different types of national health systems, and yet a lot of similarities in terms of cultural context, family structures, societies. So it's diversity as well as commonality. And my final initial comment would be that when we keep talking about the rising costs on healthcare and the financial implications, we do talk about certainly about non-communicable diseases and the growing prevalence and how NCDs are contributing in widening the gap between life expectancy and healthy life expectancy. But it's also noteworthy to note communicable diseases in the Asia-Pacific region, especially in some South Asian countries, and to just focus on the double burden of diseases like malaria and TB, which continue to be a major public health problem. So once again, we couldn't have had a more formidable panel than this to discuss these questions. Let me introduce the panelists to you. To my left is Dr. Sunman Kwan, who's the Chief of Health Sector Group in the Asian Development Bank. He has been the president of the Korean Gerontological Society and Korean Association of Schools of Public Health, and is the president-elect of Korean Health Economic Association. He is the associate editor of Health Policy, the Korean Journal of Health Economics, and Korean Journal of Public Health. It's wonderful to have you here, Sunman. Next to Sunman is Dr. Ravi P. Rannan-Eliya, who is a fellow executive director for the Institute for Health Policy in Sri Lanka. He has specialized in international public health. He has worked in Latin America, Africa, and Asia as a member of Harvard University, has undertaken research and consulted in several countries, working with World Bank, WHO, ADB, other agencies, and governments, and is recognized as a leader international expert in health equity research and health accounting. His current research focuses on issues of health system financing, aging, equity, non-communicable diseases, and child undernutrition. It's wonderful to have you here, Ravi. And last but not the least, we have Dr. Vipada, who's a professor and dean at the Faculty of Nursing, Chiang Mai University, and has been the president in academic affairs of Chiang Mai University. She graduated from the University of Alabama in USA and has a PhD in nursing services and administrative affairs. She is also a Takemi Research Fellow in global health and policy at Harvard University. It's great to have you here. So as you can see, we have a wonderful panel, and the format is that I will be inviting Sunman to make a presentation on the topic, and then I will invite Ravi and Vipada to make some comments. So the floor is yours, Sunman. Should we go downstairs? Yeah. Should we go downstairs?
Yeah, why not? Yep. Thank you. Thank you, Chair. Well, it's a great honor for me to participate in this meeting. Well, I met many of my old friends here, but many of my old friends are surprised by two of my recent changes. First, I have a very short haircut, because now I'm based in Manila. It's so hot there, so I decided to short haircut. And people told me I look younger. I'm in my 50s, mid-50s, but people think I'm about 10 years younger than my age, right? So probably I'll keep this kind of fashion of haircut in the future, okay? This is part of health aging. Another change is that I joined ADB half a year ago after about 23 years of professorship at Seoul National University. It's a new change, it's a very new experience, still learning. I'm a health economist by training, but we're broadly working on health systems and economics and financing and policy, but also work a lot on old age issues. So here in my presentation, I cannot give you all the numerical, empirical evidence on the cost, financial implications, cost of different policy choices. Rather, I'll give you what's the best way to redesign or reshuffle our health and long-term care system to respond to the needs of the older population or cope with the population aging issues. So mainly two parts, there are two parts in my presentation. First part is the snapshot, what is going on aging or health of the older people in Asia and the Pacific. And then the main part of my presentation is what's the best way, how to design our policy to respond to the aging issues. I think you've already heard a lot about these things, okay? That aging issues, and then there's a huge change in the leading causes and risk factors. Okay? For example, if you look at this daily disability adjusted life years in East Asia and the Pacific, it's a change between for the last 20 years, from 1990 to 2010. As you can see, that with the exception of HIV/AIDS, the majority of the increase increase in the total deaths are coming from NCDs, right? His ischemic heart disease, lung cancer, diabetes. Okay. And also in terms of the risk factors, with the change in risk factors for the same time period, as you can see, again, the majority of the increase in the disability-adjusted life years are coming from risk factors associated with some population aging issues like high body, BMI, and cholesterol, blood pressure, things like that. So you can clearly see that there's a change in the disease patterns and then deaths, risk factors in Asia and the Pacific. Second part, a lot of discussions, issues, and controversies over the impact of aging on healthcare expenditure. First, as you know, the healthcare spending in low-income countries are much lower than that of high-income countries. But if you look at the growth in healthcare expenditure, because low-income countries start from the lower base, so we can expect that the higher rate of increase in healthcare expenditure. And also if you compare the economic growth rate and the healthcare expenditure growth, usually healthcare expenditure is growing faster than the economic growth in the region. In high-income countries, aging still matters for healthcare expenditure. But as you heard about this, I think many times, aging is not the most important determinant of healthcare expenditure. But still, in high-income countries, it explains about 1/3 of the growth in healthcare expenditure. But, in terms of data and evidence, low-income countries, we don't have as much data and evidence compared to the high-income countries. But our guess is that if you take into account the kind of more rapid or higher growth rate in aging in Asian countries, probably it is possible that in the context of Asia, that aging may account for more than 1/3, greater than in the high-income countries in the healthcare expenditure. Another implication is that there is an intergenerational implication, such that old people, of course, they tend to spend more or use more healthcare services compared to they contribute. So there should be kind of intergenerational kind of consensus among these type of transfers. This is a healthcare expenditure per capita. This is all Asian countries, but like Australia, Japan, New Zealand, they spend much, much more than low-income countries. And this is, as you can see, the comparison between the growth in healthcare expenditure and growth in GDP per capita. Most countries, the growth in healthcare spending is greater than the growth in GDP per capita, as I mentioned earlier. This is a very kind of important figure that I would like to emphasize, because this shows a very clearly what is the impact of aging on expenditure, or broadly, what are the determinants of healthcare expenditure. As you know, the per capita health expenditure usually have a U-shaped curve, right? In other words, for children, they spend a lot, but with age, it's decreasing. When they become teenagers or adult, the healthcare utilization cost is decreasing, and then with aging, is increasing. At the top right-hand side, it's a slip. It's a decrease because it all depends on where people die and what is a kind of spending at the end stage of life. But this is typical U-shaped curve. Aging may have an impact on expenditure in several different ways. First, pure aging impact. Because more people, aging means more people are, with age greater than 65. So even if the U-shape stays the same, more people move to the right on the curve, so that more people. So this is a pure aging impact. More people, located on the right-hand side of the curve. Another factor on the right side is non-aging drivers. This is very important because when income increases, people tend to demand more because healthcare is a normal good in economic jargon. And people demand for high-quality healthcare. So even without any aging impact, the healthcare expenditure for all age groups tend to increase. So the whole U-shaped curve moves upward. But most important element we should consider in the context of aging is this side. Okay? So this one, ideally, or in many cases, this original U-shape moves to the right. There are many factors. There are a lot of discussions on the importance of end-stage care. Okay? So a lot of empirical evidence, mainly from the high-income countries, show that people spend majority of their healthcare spending in the life course at the end stage of life, last half year, 1 year, 1.5 years, 2 years. Okay, so how to contain the cost at the end stage of life, or so-called proximity of death argument, matters a lot to determine the life course healthcare expenditure. Another element is that, well, health outcomes, health status of 70-year-old person today should be much better than the health status of 70-year-old person 10 years ago. Of course, there's argument between compression of mobility or expansion of mobility, but many high-income countries showed some evidence that there is a trend of compression of mobility. So in other words, there's an increase in life expectancy is more coming from the healthy life years rather than unhealthy life years. But the question is whether this type of compression of mobility can be realized in many low-income countries. Because some evidence shows that people live longer, healthier in high-income countries, but that is not the case in low-income countries. And even in a given country, we should pay attention to the so-called equity issues, such that in the same country, high-income people, wealthier, richer, they tend to live longer and healthier. But low-income people or people with lower socioeconomic status, even if they live longer, but they live longer but unhealthier. Okay? But this is a very important thing. Okay? How, as is it like healthy life years, or how to manage it, the end stage of life. It has a huge impact on the healthcare expenditure. But as I mentioned, the intergenerational implication is very clear. This is data from Japan. Okay? As you can see, it's like a wage. So people in the production age, they contribute more to the system as a contribution, for example, premium contribution. But old population, they spend more because healthcare expenditure, again, this is a U-shape, right? This is a per capita healthcare expenditure. So old people, they spend much more than they contribute. So this is a very typical trend. And as I said, most countries accept this type of transfer, but this is a very clear implication for the intergenerational transfer. Then, living longer is a fortune, it's a blessing. Okay? So our goal is how to, redesign, reshuffle our healthcare system to maximize the positive impact of aging or minimize the potentially negative impact of aging. Financing. Well, UHC is one of the main agenda of new SDGs. So we need a government commitment to universal access to healthcare for all ages, not just for older people, but UHC means for everybody without financial hardship. Okay? From efficiency perspective, UHC can contribute to the health improvement of older people. Okay? Right? And then it reduces the need for long-term care. So it improves both efficiency and equity. But for UHC, in the history of the UHC, there is as far as I know, only the mandatory public financing can achieve the UHC. We cannot achieve UHC relying on private source of financing. Okay? And even in the public source of financing, I mean either government direct tax, government taxation, or public insurance or social health insurance mechanism. Or even in the social insurance mechanism, without subsidy to the poor cannot afford to pay contribution. So without subsidy to the poor, pure contribution approach, it is very difficult to achieve universal healthcare coverage. But we should also pay attention to the benefit packages of healthcare financing, okay? Because we need to expand the benefit packages to respond to the needs of the old people, to cover the NCD issues and services for old people. And in that context, medicines is very important, as you know, because old people rely more and more on medicines. So coverage of medicines in the benefit package of health insurance is very important. This is a financing mix of healthcare expenditure as a percentage of GDP in Asian countries. So as you can see, low-income countries tend to rely more and more on private healthcare spending. So it means that people in those countries face huge financial barrier to the access to healthcare. But this is the questions that I often been asked because I've been working on healthcare financing for a long time, and people say, well, why should we have a separate financing for old people or separate financing for NCDs? If I attend a meeting in hepatitis C, people there are interested in, this is very serious illness, so should we have a separate financing targeting this area? Usually, my answer is no. Okay? From efficiency and equity perspective, we need UHC cover health, not all services, but cost-effective healthcare services for all age groups, okay? Rather than targeting. However, we can design the benefit package as I mentioned earlier. For example, if you think that there are many poor, vulnerable older people, then we can reduce copayment, or we can exempt the user fee for older people. Again, the issue here is that some older people are very rich in some countries. Okay? So whether we should provide kind of a unconditional, kind of a lower user fee or exemption of user fee for all older people, or again targeted the poor, there might be an issue depending on the context of your own country. But also we need to pay attention to the special needs of older people. Okay? Because old people, it's more difficult for them to move. So we need to provide additional special benefits for them, like transportation, okay? For them to access to healthcare facilities more effectively. There also, we should reform the service delivery and human resources system. Many healthcare systems in Asia is not ready to respond to the increase in NCDs and aging issues. Over-reliance on hospital care with very weak primary care gatekeeping and very weak referral system is so common in many Asian countries. This is very inefficient healthcare system. I'll also talk about the coordination between healthcare and long-term care. My experience, from my own experience and also kind of literature, research shows that whenever you have a very weak primary care system, whenever you have a very weak referral system, we can rarely expect a good coordination between healthcare and long-term care. So gatekeeping, in most cases, primary care is also very important. And as I mentioned in the U-shaped graph of healthcare expenditure, end-of-life care, hospice care, palliative care also affects the healthcare cost. But it's not just the cost, but it's the quality of life. Okay? Dying in hospitals, is it humane? Okay? And also, as I said, most countries in Asian countries have not established a long-term care system. Okay? Currently, the care for older people or long-term care is handled by or provided by either by hospitals or by informal caregivers, like families. And also, as I mentioned earlier, pharmaceuticals, medicines is a very important element. So there's a lot of potential efficiency gain or equity gain if we, design or if we have a good policy for medicines and pharmaceuticals. So, and also the service delivery system reshuffling request the reorientation of education and training programs. Okay? Because current education and training program for medical professions is not, it cannot deal with the healthcare needs. Older people, it's not just a comorbidity. They have a multi-morbidities, 5 or 6 diagnoses. But current very specialized silo system of education, after that education and training, medical doctors, they cannot cope with those multi-morbidity issues. So the current curriculum should be redesigned to include the needs of the old people, geriatric health, health promotion, disability, because for old people, it's not just a treatment, but it's a maintenance, promotion, rehabilitation. It's so important. And also, as I mentioned earlier, empower the primary care and gatekeeping. I think this is a very important issue. It's not, because we all agree that primary care strengthening is a low-hanging fruit for universal healthcare coverage. But it's not just for UHC. But for aging of population, really, this primary care gatekeeping is one of the key factors to improve the health of all the population through like a risk factor management, screening, education system. These kind of services can be effectively provided and managed by public health centers or primary care level providers. And also, we should pay attention to the training of the long-term care providers. Okay? It can be formal care providers, but in case of family care providers, we can use some kind of training programs for those informal caregivers. Long-term care systems. This is a lot of discussion also on these issues. You know, in many countries, whenever there is an increase in the education of the women, women's education means that the more labor participation of the women, and usually lower fertility, and those are change in attitude for caregiving. Because many people in the Western Europe, they think Asia still have a family value. It's true, but it's rapidly eroding. I'm from Korea, China, Japan. It's rapidly eroding. We cannot simply rely entirely on the family for long-term caregiving. We need a kind of social, kind of government level, some interventions, some provisions. Okay? And also in terms of efficiency, again, you know, healthcare and long-term care are interrelated, such that if you have a good long-term care system, they can reduce the unnecessary social admissions. If you don't have a good long-term care systems, then people tend to stay longer in acute care hospitals. It's very costly. Okay? So increase in the supply of long-term care systems have a positive impact in reducing the unnecessary social admissions in acute care hospitals. And also, long-term care can be provided by either institutions or community-based care or daycare centers or home-based care. So these kind of various effectively designed long-term care system can improve the quality of life and save healthcare costs. And there's kind of consensus that we need to avoid and reduce the over-reliance on institutional care, because we should not build too many long-term care facilities, too many nursing homes. So that the supply of providers should be based on the careful planning. I mean, the ideal system of long-term care is what? The ideal system of long-term care means that the older person, without financial hardship, they can choose freely where they want to stay. Some people, they may want to stay at home with caregivers visiting home. Some people, they want to stay in the institutions. And also depending on the severity. If an old person has a very severe functional disability, they cannot stay at home. It had better be cared at the facilities. Or in the middle, like a daycare centers. Okay? In the morning, adult child brings the family at the daycare center. They spend the daytime with friends, community members, and they come back at night. So kind of continuum of care. And people should be able to choose freely based on their need, functional disability or need, and the preference. In Japan and Korea, they have a separate insurance. In other words, they have a medical insurance, health insurance, and they have a separate insurance for long-term care. Well, there are pros and cons. Although I'm from Korea, I usually suggest that, it's an option of your country In some countries, you may want to have a separate insurance, health and long-term care. Other countries, you may have one integrated system. There are pros and cons. First, the benefits of having separate insurance scheme is that we can demedicalize the social care and long-term care. Because if the social care or long-term care is integrated in the health insurance system, maybe medical profession is too dominant, right? So even though some of those social care components can be medicalized and too expensive. So separate system has a benefit, potential benefit of a demedicalization. But there is a cost. It's a separate system. It's a coordination failure, right? Because it's a separate system. So there are pros and cons. Okay? So you should take into account those systems. And another thing is whether, another question I often been asked is that whether it's time to, when is the right time? I mean, when is the right time to have a kind of long-term care financing system? My usual, ordinary, I mean, in general, my suggestion, policy recommendation is that if you have an existing healthcare financing, you can extend the benefit of existing healthcare financing toward old people, okay? Rather than suddenly establishing a new separate one. So expand the existing one and see whether it works. Okay? So that's my suggestion. Expand the benefit package for the elderly in the existing healthcare financing system. Coordination, this is my final point. It's not just a ministry problem. In many countries in Asia, there's a separate Ministry of Social Affairs, Ministry of Health, they are separate. So which ministry should be in charge of this long-term care is always an issue. Sometimes conflicts, fights among these two ministries. Some countries, Japan, Ministry of Health, Labor and Welfare, so it's the same, in Korea it's the same, Ministry of Health and Welfare. But that does not mean that there is no conflicts. Even in the same ministry, they are in the different bureaus in the same ministry, so there are sometimes conflicts. But this coordination is one of the key concerns. Okay? And also, which should be given a higher priority between health and long-term care is a very delicate question. I'm working on both health and long-term care, but my suggestion is, well, health and long-term care. Here, long-term care, I mean more like a social care component. Sometimes healthcare means sometimes life and death. Social care, long-term care means more like a quality of life. Of course, quality of life is very important, but you should trade off this, which is more important. My opinion, or in the history of many countries in the world, they first achieved the UHC, and then moving toward the universal coverage for long-term care. But again, there might be some kind of some counter-argument, because in most countries, most high-income countries, they achieved the UHC right after the Second World War, 1950s. At that time, they did not have a huge aging problems. So in a sense, historically, in terms of timing, they extended healthcare, and then they faced the aging issues, and then they expanded long-term care. But still, even now, if we have the same kind of issues of health and long-term care, I think ensuring access to healthcare for all age groups without financial hardship might have a higher priority than to ensure universal access to long-term care without financial hardship. But again, it's your choice. It's the choice of your country. You should have a consensus. But my opinion is that healthcare system strengthening might have a higher priority than the long-term care system. So strengthening the coordination, like continuum of care, overcome the discontinuity, fragmentation from like a primary care, acute hospital care, geriatric hospitals, and community-based rehabilitation, community-based care, home care. This whole continuum of care should be kind of strengthened. And of course, we should encourage the deinstitutionalization, and we should encourage the community-based care. But again, as I said, if the old people is functional status is too severe, they cannot stay at home, no. So we should take into account the severity functional status of old people and their preferences, as I mentioned. Let me conclude my presentation by giving you some bad lessons you learned from Korea. Fail, I just say, I often say professors are born to criticize. So I criticize a lot of this failure of collaboration between healthcare and long-term care, or health insurance and long-term care insurance in Korea. Currently, long-term care hospitals, there's a typo. I'm sorry, you're right. Long-term care geriatric hospitals are covered by health insurance because they're hospitals. Long-term care facilities, like a nursing home, they are covered by long-term care insurance. In theory, people should, as I mentioned earlier, people should choose which one to be admitted based on their preference and based on their functional status. One of the rationale of introducing this long-term care insurance in Japan and Korea is to reduce the social admissions in hospitals. But especially in Korea, still, many old people, they want to stay in geriatric hospital rather than move to long-term care facilities. Why? First, these are gray areas because, as I mentioned, old people, they always have multiple kind of health problems. So when they are away from hospitals, they feel sometimes uncomfortable. They want to stay close to the hospitals. So, in a sense, we need to coordinate the benefit packages of these two insurance mechanisms, or fee schedules for providers among these two, insurance mechanisms. So that is very difficult so far. As I mentioned, there is little gatekeeping. Almost all providers are specialists. So in Japan, Korea, many, even Germany, the majority of the doctors are specialists. So little gatekeeping. Because if you have ideal gatekeeping, when an old person comes to the system, the gatekeeper decides where to go, where to send this old person. Is it primary care or hospitals or even long-term care facilities? But there's no gatekeeping. So where the old person first visits, first encounter of this, it matters. And also, hypothetically, there's a big argument between health professional and social welfare professional when we introduce long-term care insurance. Because social care expert or social welfare expert, they think these long-term care facilities, long-term care institutions are social care agencies. They don't need any health care. So our law says the minimum requirement for these long-term care facilities is just a nurse aide. Although we strongly maintain that the minimum requirement should be registered nurse, at least, licensed nurse for these long-term care institutions. So for patient perspective, they are worried. They are worried, in a sense, worried about moving to long-term care facilities because if they go there, the medical capacity in that institutions might be too low. So this is a bit paradoxical kind of argument, but there are a lot of discussions. And another major factor is that, now I'm working in ADB, private sector is very important. But there are a lot of problems in the private sector. Right? In Korea, the majority of the hospitals are private. So geriatric hospitals, long-term care institutions, they compete for patients. Referring patient means a loss of money. So kind of wasteful competition among private providers is another kind of a factor. So you can learn about this. Why? Why? Because this coordination failure is a big, big issue. But why in some countries face this coordination failure? I think there are a lot of policy lessons for you. So in summary, this is a data, but I can summarize. In summary, aging has a big impact on expenditure healthcare system. But for us, our job is to reshuffle or to make our health systems can better deal with this aging. This is, as I said, it's a blessing. Living longer, why is it's a blessing? So, but there are a lot of challenges. But if you have a good policy design for health systems, we can deal with it, and we should deal with it. Thank you.
Thanks, Sonman, for a very rich presentation in which you described how some of the future directions could be. And some very interesting observations come from your presentation, the need of universal health care, which a lot of countries, a lot of governments have been trying with mixed success. And a goal, as you mentioned, has not been able to be achieved in many countries in comparison to high-income countries. And then the quality components of services and the human resources. And you did mention that high cost sometimes does not correlate with the quality which is required. And then the whole focus on long-term care, which seems to be a solution with deinstitutionalization, as well as with activities based in the communities, community-based care, and the coordination of healthcare and long-term care. So that's what I take from your talk. Ravi, your areas of research are health equity and aging. So I think you are in a good position to provide some insights. So I'll invite you to speak.
Thank you. And I'd just thank Sunman for really, I think, quite an excellent overview, I think, of many, if not all, the issues and what I think is a very complex challenge that we all face. And I have to say that in general, I basically agree with the thrust of what Sunman was saying. I mean, I think that really the key points that he makes about what we need to do is very clear. So I want to just comment more on some of the, kind of re-emphasize some of the issues and maybe draw some nuances that he hadn't drawn. The first thing, I'll just sort of go through the order of his slides. The first issue on the risk factors, I mean, he showed us that, the risk factors increasing, smoking, obesity, various other things. But I think, let's be quite honest, really the big elephant in the room for us, and particularly for the public health community, is obesity and overweight. The world has done a really great job on combating tobacco. And you saw that on his slide. Tobacco is really not going to be that important. I know there's still a lot more people who are smoking and a lot more people are going to start smoking, but we have the tools to be able to deal with the tobacco epidemic, and in some countries we've made enormous progress. Obesity and overweight is something we really have right now no available population level interventions that actually work at scale. We still really have no idea what to do, whether it's OECD developed countries or whether it's Asian countries. And I think really for all of us, that, including Asia, we have to do far more in trying to figure out those interventions. And I should just point out, obesity, overweight is also related to the other risk factors on his slide. So things like hypertension, hyperlipidemia, these kinds of things are also related to obesity. So obesity is really the critical thing that we need to do something about. Now, the other thing I just want to raise that is the issue of long-term care. And, we have this issue of health and long-term care. Are they separate problems? A lot of long-term care is based on physical frailty. And I would just note there's a lot of research coming out suggesting that a large component of this frailty in certain individuals, because not everyone ends up being frail and needing long-term care, a large component of that appears to be driven by subclinical atherosclerotic disease, which I think, again, goes back to the obesity overweight issue. We really need to, I think, find solutions, and we don't have them right now, find interventions. Next, just in terms of cost drive, I think John Beard said earlier this morning, someone said aging is really not the big cost drive. I think really for most countries in Asia, it's going to be expanding coverage. Countries are committed to doing that's going to really increase costs. Aging is just, you're going to cover NCDs and the elderly. Well, if you're going to expand coverage, you have to do that anyway. And really the important thing to note is the thing we need to worry about is that how do we control costs in these systems? And some systems are far more effective in controlling price inflation, healthcare costs. I noticed there was a slide earlier, referred to the earlier session on the United States. Part of the reason I think the USA, and the US has particular problems with this, you saw that very large increase in spending with the elderly in the US. Part of that is related to the fact that in the US, very unusual, only the elderly have UHC. So part of that is not just an elderly issue, it's partly a lack of UHC in the rest of the population. So I think we have to have UHC, but we also need to think about what are the things we need to do to keep costs under control. And I think it's a cost issue because of public fiscal implication. There is this issue about compression of mobility. I think you mentioned that. I have to say we really don't have any good evidence on this for developing Asia. I think this also another issue. I suspect the evidence is mixed at the moment because of the impact of treatment. I think if you go back to the frailty issue and the role that obesity and atherosclerotic disease might be playing, it may well be that health systems that treat people at a younger age effectively, and I say treat because you can't just prevent all NCDs. You have to treat some of this stuff, and it includes secondary prevention. Maybe health systems who do a better job in middle age at younger ages may end up having less of a burden when it comes to older ages. And I think that there's a sort of linkage between that. But we still don't know, I think, what the evidence is on trends. And we probably need to do a lot more to understand that. I want to just turn quickly to what do we do. I would echo what someone said, and I think again what John Beard said earlier about, is this really a cost? I mean, today's elderly people were yesterday's young people. And all the young people in this room here, all of us today, are going to be elderly in future. So basic equity and I think solidarity concern requires us not to really put these different groups in together. So we're all going to be elderly, right? And the other point to make is, throughout our history as a species, we have striven to live longer, right? One of the fundamental desires of most societies has been to live longer, if not to have immortality. And yet, when we succeeded in getting that, we suddenly think this is a problem. It's not a problem. It's actually a success, but we need to reorientate how we think about this. And I think part of the solution for me really goes back to a similar solution that we face with pensions and old age income security, I think is the other room. I think ultimately the solution is, if we're all going to live longer, and this is really the problem in pensions, we have to contribute and work longer. If we do that, if we make use of that life, then financing the final stages of our life is not a big issue. And I think for healthcare, you had that nice chart of contributions and beneficiaries by age. The issue is this: if we're going to live longer, we can continue paying into a system and paying for the old people who really need that elderly healthcare and long-term care. I don't think it's necessarily such a problem, but we do need to reorientate how we think about who's elderly, who should be paying and who should be paying out and who should be working. Fundamentally agree, can't solve any of these problems without public financing. We think we're going to do this through private financing. It's not going to happen. And long-term care is just impossible, I think, with long-term, with private financing. And I think that's something that ADB also, there probably needs to be more discussion within ADB about that, I've noticed recently. Just one caveat on someone's issue about medicines. I think we all agree most medicine spending is inefficient, irrational, etc. Huge scope for savings. So absolutely agree on that. But we also need to note that for old people in general, there is huge, despite all the overspending, inefficiency, huge under-provision of essential effective medicines for older people, particularly for NCDs. I'm doing some work in Malaysia right now. Malaysia is a relatively well-funded, organized healthcare system, but even in Malaysia, huge undersupply of relevant NCD medications. So even if you improve efficiency, let's not forget, reality is we're going to have to substantially increase supply, and that may actually end up costing us more. And Sri Lanka, we're a very efficient purchaser of medicines, but we actually spend even more than other countries, a bigger percentage of our budget on medicines than other comparable countries. And that's despite efficient purchasing. Next, and one other comment just on medicines. This goes back to the UHC problem of public financing. I think one of the solutions to this inefficient purchasing is actually related back to the issue of public money. If we use public money and if we have integrated financing schemes, it becomes much, much easier to achieve lower costs in purchasing, and more importantly, to use the power of the state or the collective funding mechanisms to force prices down in negotiations with the people who produce the medicines, the manufacturers. Finally, just one caveat on the issue of primary care. I agree with strengthening primary care, but I'll give you a caution. In Sri Lanka, and I think someone mentioned the issue of screening, Sri Lanka's done an incredible job recently in establishing a nationwide network of NCD screening clinics. And being Sri Lanka, this more or less works. We have about, I think, 800 clinics now, nationwide. But actually the reality is most of the people who end up being diagnosed and put on the necessary treatment for NCDs, particularly heart disease and diabetes, are not being found in those clinics. They've been found in the rest of the healthcare system by other doctors in hospitals and other kinds of clinic, even specialist clinics. And that gets back, I think my kind of reflection on that has been, we don't need to have separate screening primary care programs. We need to mainstream screening, secondary prevention, management of all these problems, management of the elderly, into the main health system instead of segregating into some kind of ghetto. Because the reality is, every time a patient comes into a doctor's clinic, whoever that doctor is, the doctor should be doing the appropriate things. Okay. The second point to make is, and again, this is an issue we've had in Sri Lanka. When we first started, looking at NCDs and Sri Lanka started to screen people, they started screening people but had no plan to give people the treatment. I think it's completely unethical to screen people if your public sector, especially in the public sector, if your public sector has no plans to buy the medicines that many of them are going to need. So I think we have to combine screening with adequate financing and supply mechanisms to ensure that people get the treatment that some of them will need if we screen them effectively. Thank you.
Some very important observations, Ravi, thank you. In the interest of time, because we need to have some time for the discussions, I'll invite Vipara to make some comments and then we open up.
Thank you very much, Bhagat. Actually, I agree with Ravi in some points, but I will gonna make my comments based on my as a different point because we don't have a lot of time. It's the same issue. So in my points of view, I think that I agree with many points that Sunam presented about the need of a health system reform for the older people. And I think that the leading cause, I just want to add a little bit from where we spoke about obesity, and Sunam talked about some of the problems in Southeast Asia in terms of the food, and I agree that one. But in Thailand, we have some problems about raw food, and so it lead to many problems, health problems. But obesity is also should be focused because it is not from Thailand or from Southeast Asia region, but it's from Western country too. It makes now we have obesity in the children, and that leads in the future of the elderly people that should be lead in the chronic disease in the future. So this is, I think that is very important. And the other thing is also about smoking. We talk about smoking. I think that we should concern about second-hand smoking and also the third-hand smoking that will cause many lung diseases and for the adult and also in the elderly in the future. And another thing that may leading cause is the environmental, because in Asia and in Southeast Asia we also have some like a burning that lead to smoke and many problems, cause a lot of lung problems also. So that is in terms of the leading cause of and also the indicator. So then I'm going to go to the policy choices of a system reform that Sonam presented about that. I agree in many parts. As you see, as a need governmental commitment, yes, I agree with this one. And it will all health accessible for all age, and so the elder may feel better and confidence and will not be, especially in the Asian part, that it's not a burden of the family in the future. So it's make better confidence. And so, and because in the elderly time there no income, enough income like in the adult era of life, and it is also improve the health equity. And yes, the essential medicine for the elderly and others. This is I agree with Ravi. But the additional needs like transportation, this will cost more the budget of the government. And I'm not sure that if we have enough, because it's not just a transportation, but it may have some additional needs that we have to prepare for the elderly. And if we have enough budget, it will be good for the elderly, I think. And also, I think that in terms of UHC, it is a better health of the elder people and reducing the need of long-term care. I agree in some point, because in terms of if we focus on health promotion and prevention, it will focus on beside not just only curative, but in the real situation, sometimes we focus on curative more than preventive and promotion. That costs a lot of money that we spend for the if we have a UHC. But it is a good for because it's like a commitment, and it's good for the elderly for the in the UHC. And so I think the package should include the promotion and prevention curative. Actually, Sonam talked about that one, but I think that in the real situation, we should focus more in terms of promotive and preventive. And for the second point of the policy proposed in terms of service delivery and human resources, I agree in many points too. And for the first one is like for the reoriented to the response of the increased NCD in aging and the over-reliance on hospital care. I just would like to give an example of the city of Chiang Mai. I stay there. And in the university hospital, there's so many patients come, even though they have a chronic illness and the situation that doesn't need to be come to the university hospital, but they do. A lot of patients in the OPD and IPD now, because we do not have enough long-term care facilities in Thailand yet. Because they just say that this is a belief of and the attitude of the people say too, that they want to die in the best hospital. So that's we still have a lot of facing with service delivery in Thailand, and also in long-term care facility. I think that is not enough, as I already said. And in terms of health profession, especially physician, they still become more specialty. It's like a small specialist in terms of we not have. I'm not sure that they have enough GP or not to serve in the primary healthcare settings in the rural area, and I think the teamwork is needed in countries in Asia. So the in the university and college is very important, like we do if we can do like interprofessional education, but this is still in a process in Thailand. Not very every university can implement interprofessional education yet, because after graduate it's very difficult for them to work as a team. And the curriculum should you propose that the curriculum should be include elderly aspect. Yes, in Thailand, we include in nursing curriculum as the elderly care course. And we also have a focus on elderly as one of the 8 subjects that nurses will take the license examination. So this is some preparation, but I'm not sure that every countries or every college will have implemented a curriculum as well as in terms of the health promotion. Actually, I just talk in terms of the nursing field, because nurses also view a lot of health promotion as a main priority to take care of the patient or the people. We do a study that how high is the level of nurses who provide health promotion. We found that not a lot, even though they may not know that they do health promotion, especially in the tertiary care setting. And I think that this is a need. I agree with you that we need to have more in terms of health promotion and also prevention in our curriculum. And have a model that we should do in terms of like a learning center for the student to learn. Once they graduate, they can be like a health profession that can conduct like many kinds of things in terms of prevention and promotion. And the third point is in long-term care system. I agree that this will be very benefit for all elderly in many countries, but it may cost more in terms of long-term. We found that I agree with Sonam that it's different in each country and the situation in each country. Like in Thailand, we found that in one study of Dr. Verwit in Chulalongkorn University in 2011, they proposed that who are the caregivers of the older people. It's interesting that 55% are daughters, 36% are sons, 35% are in-law, and 37% are nephew and niece, and only 5% are paid carer, and 6% are servant or employees. But that is already 5 years ago. So I think that may be changed. Now we have a lot of like elderly parents in our school. So each family may have at least one caregivers, the paid one caregivers. Yeah. So this is very important. But anyway, I think that the most important thing is the quality of long-term care facility that we provide and the program that if we can choose what is the need of the elderly people, that will be the best, I think. And the fourth point that Sunam talked about, coordination of healthcare and long-term care. I agree that the coordination among the MOH and social welfare, but I think that it depends on each country, whatever the responsibility of each minister. But I just want to add in terms of private and public too, because it will be difficult for only public to do a planning, but without the private understanding, really understanding. So I think that if we have a coordination among public and private sector too, and also the involve of some of other minister too. Yeah, I think that is for the long-term care is very excellent proposal. But I think that the balance of the financial support and sustainability is very important, as well as the quality of long-term care provided. And I think the most important is the physical, mental, spiritual of the older person. And I think that is very important in this changing society. Thank you.
Thanks, Ravi, and thanks, Vipara, for your comments. I will make a few observations and then we'll open the floor. Mapping the risk factors and the changing NCDs epidemic shift to Asia and to rural parts of Asia is something which is very important. We definitely see this growing prevalence of obesity epidemic, as well as diseases like hypertension and diabetes, which are easy to manage if diagnosed and controlled, which definitely is an important contributor to reducing the costs and the financial implications. I cannot agree more on the primary care importance, and Sri Lanka is definitely one country, from my experience too, which has been the leading country in the SAARC region on NCD control, primary care setups, and has shown the way. So that's probably the way to go forward. And then the whole emphasis on long-term care to make it qualitative, to make it more community-based, looking at the cost. And Vipara, you very interestingly shared the experience of how the nursing curriculum in Thailand has this special focus on elderly care, which I don't see is happening in a lot of other countries. So there are some good notes to take from these comments. We need to finish by 12:30 or so we don't have a lot of time. But we can still go for a couple of rounds of questions. I'll open up and I'll take 3 or 4, and then we'll let the panelists answer. We begin with you. Yeah. You. Yeah.
Hi.
Could you please identify yourself?
Hello, I'm Chris Herrera. I'm from the Philippines, Merck Philippines. Is my mic working right? So basically, I picked up on the biggest risk factor is actually obesity, high BMI. Now, taking an evolutionary biology perspective, I think that this is primarily because of the incompatibility of our modern lifestyle with the diet and how we were evolved. Because if you look at how we evolved as humans, we are craving for salt, for sugar, for fat, because these are high nutrition foods that are essential if you're a hunter-gatherer. But now we have a sedentary lifestyle. We have McDonald's. We can deliver food at the doorstep. And compared to before, when we were hunter-gatherers, we had to chase our food. Now we can just text it or put it online and it goes to our doorstep. So my question is that probably this kind of risk factor is driven by the incompatibility of our modern lifestyle with our biology. And frankly speaking, I think that just information and education campaigns don't work. Because I think most people are already aware that you shouldn't eat too much fat foods, but you just drink so much soda anyway. What is your take on stronger regulations to moderate this behavior, such as the sugar tax or maybe the fat tax, where we actually tax people for being overweight or obese? No, that's kind of a hardcore thing, but just putting it out there for your views. And secondly, this is a more fundamental or more philosophical question, is that my personal take is that we have higher NCDs, and it's a trade-off for having lower deaths from infectious and acute diseases like getting eaten by a lion or an alligator. But the fundamental question I think that the medical field has to move on is not just the extension of life or prevention of death, but actually how do you make people more productive throughout this entire thing? It's a common theme that we've all touched on, but I think that the medical field, which I think is hopefully represented well enough here, has to change philosophically, not just preventing death, but improving life. So thank you.
Yes. Yeah.
Thank you for the very good presentation. I'd like to comment on Dr. Suma's Kwon's slides. I come from Singapore. My name is Wai Chong. I'm a family physician with South Foundation in the community. So there is a saying in Singapore, it's in Teochew, Di Go Liang, Di Go Zhou. What it means is, whichever has more shade, it's where you will go and sit under. So if you have universal health insurance, UHC health coverage, usually what it means is hospital coverage. So you get a lot of people going to the hospital, going through the emergency departments. And then if you have long-term care insurance, you may also drive behavior that way. So what I'd like to just bring up and for you to comment on, because you talk about the purpose of UHC and long-term care insurance, you mentioned something like to avoid punishment and hardships. But just wondering, could we sort of reframe the purpose of financing policies to sort of incentivize healthier behavior, more effective and efficient health-seeking and care-seeking behavior? So I'm actually thinking what you think about a way of incentivization of that people actually gain by being coordinated, being having a healthier behavior, and perhaps some kind of system whereby primary care is where the hub of the health rather than hospitals or even long-term care insurance, long-term care institutions. So that's my comment, yeah.
Yes.
Thank you very much for a wonderful presentation. I couldn't agree with you more on the need for, as you said, deinstitutionalization, home care and community care. And I think our health systems, which are actually 6 systems, we call them health systems. They are 6 systems in more ways than one. They are in urgent needs of reforms, as your topic is. But what I feel strongly is if I can't measure something, I cannot really understand it. And if I don't understand it, it's very difficult to change or reform it. So I would love to know your thoughts more about the importance of data collection and interpretation. We haven't really touched upon that. And it is very difficult for us to get data from most of the countries that we are working in here. Yesterday we saw that most of the countries have never ever done an age-specific survey at all. So do we really need to put in investment into this more, and what will be the returns of it? What are your thoughts on this? I would really like to know. Thank you.
Maybe a couple of more questions. Okay, 3 more.
Okay, thank you. When we are talking of the policy choices, shouldn't we talk about also health education, you see? Most of the NCDs, non-communicable diseases, are related to the lifestyle, If one changes their lifestyle, like doing exercise, avoidance of smoking, and cutting down on alcohol, losing weight, controlling of hypertension and diabetes, I think that will help quite a lot, you see, to ease the burden of the the morbidity in the senior citizens. So I think this should also be considered when we talking about the choices. I think that should be considered. Like yoga also, I think, is very important in this aspect. Thank you very much.
I'm Dr. Wendy Holmes. I've been working on the Better Vision Healthy Aging project in Sri Lanka. I would be interested in the panel's comments on the problem within the public health sector of doctors, specialists, corrupt specialists who charge within their public health service, who charge patients for example, intraocular lenses or for particular medicines from which they get commissions, and the difficulty of being able to curb those unethical practices because specialists are in such short supply and are able to leave the country. And I think it's a very major and very hidden issue. And part of the problem is that the professional colleges really behave as cartels, and because they're responsible for training and limit the number of specialists there can be and protect each other. I think it's a very, very difficult problem, and I'm interested in the panel's response. Thank you.
We take just one more, you, Ajiba, and then let the panelists respond, and then see if there is time for more questions.
Thank you. I'm Ajiba Islam from HelpAge International, working in Pakistan. I was wondering do we have any cost models of home-based and community-based cares developed so far? And when I say cost models, I would assume that it also takes into account the opportunity costs of family members and community members being involved in providing long-term care for older people. Do we have any examples for sharing with our governments and policy makers in our countries? Thank you.
So should we begin with you and then, yeah.
Thanks a lot for all those important comments. First, obesity issues. I agree with that. Obesity is one of the these days fundamental root causes for many of those risk factors and health problems. The question is, as raised by two of you, what is the best way to deal with these problems? I think it's not just one or two interventions. We really need a multiple kind of coordinated interventions. For example, lifestyle, we all know lifestyle matters. But sometimes, as you mentioned, people do not change their behavior, their lifestyle. So we also need some kind of economic incentive, financial incentive. Taxation is one thing. And also, in these days, in many high-income countries, like a community design and urban design are a lot of being discussed. Okay? Because how to make people, how to encourage people to walk, to exercise. It depends on whether they have a better access to public sector kind of a community level exercise facilities, or how the road system. So, for example, in Korea, I observed when I was a child, we built all those what is that highway system in the traffic design. So, but now we demolish some of them, and we make more space for pedestrian crossing, and we build more exercises facilities in the community. So these days there are a lot of so-called in the urban health domain. There are a lot of discussion on what is the best way to promote health of not only the elderly but all the population, but a lot of discussions on urban design, community design for older people. So I think we need a multiple kind of good coordinated effort, interventions to cope with this obesity and health promotion issues. And also health aging. Again, it's not just medical care. We all know that to improve the health of older people, participation is so important. participation in the religious activities or social activities, community activities. So we really need, I mean, in a sense, although we all know the importance of social determinants of health, but these social determinants of health is even more important in the context of health of old people. So medical care is not enough. We should work with other issues. First, I'd like to clarify one more time that UHC does not mean the universal health insurance. As I said, UHC means we need to rely on some kind of mandatory public financing, either tax or insurance, to ensure access to all essential necessary services. It's not just the hospitals. Look at the UHC of many other countries. They guarantee access to not only for hospital care, but also for primary care. This is very essential. In a sense, we should design the benefit package such that people have more incentive to use primary care rather than hospital care. And also, in some countries, in European countries, OECD countries, they do a lot of so-called P4P, pay for performance measures. Incentive is given to primary care physicians such that the financial incentive is given to the primary doctors if they keep or improve the health of the population in the catchment area. For example, they measure the blood sugar level or BMI at the beginning of the year and at the end of the year. Of course, this type of system works only when we have a very good primary, well-established primary care system. So that's why I keep emphasizing the primary care is so important. And I agree with Ravi, it's not just the existence of primary care centers, but they should have a capacity or human resources to provide adequate care. Data collection and interpretation, as a researcher, as an economist, of course, I fully agree. We all agree with the importance of data collections, and also this data collection is more like a public good aspects. Private sector has little incentive to do it. So again, it's very important for the government to invest in the data collection, interpretation, and research. That's the way toward the evidence-based health policy. Corp physicians, I fully agree with you. And also there's a slight discussion on the public-private partnership. I think healthcare and long-term care, there's a slight difference because the role of the public sector is very important for example, in healthcare because so-called there's market failure in healthcare. Why? There's information asymmetry between providers and consumers. So to solve this information asymmetry, because consumers have difficulty in evaluating the quality of healthcare, so we always advocate the public sector role in healthcare. But in long-term care, again, consumers have difficulty in evaluating the quality, but compared to the healthcare, consumers can, comparatively speaking, less difficult for consumers to evaluate the quality of long-term care. So that's why in majority of the qualities, the role of the public sector in delivery, service delivery side, the role of the public sector, role of the private sector in long-term care is slightly higher than the role of the private sector in healthcare delivery, if you look at those delivery systems in other countries. Cost of home care, as far as I know, I don't have any evidence in these Asian countries, but in European countries, many evidences shows that home care is not necessarily cheap because it all depends on the quality of long-term, home-based care versus institutionalized care. And as we mentioned, once we take into account the opportunity cost of the informal caregivers, and also, if you compare home care and institutional care, there are definitely economy of scale in the institutionalized care. So, in a sense, which one to choose, as I mentioned, is not just a cost concern, but what is the preference of old person? Okay? Because other things being equal, old person, they want to stay at home because it's more familiar. But if they are very severe and if they don't have any caregiver available in the home, they should definitely move to the long-term care facilities. But the best system is that the way we should be able to give choice to the old person.
Just to pick up on the last point about cost, and relating to your cost models. I think one thing to emphasize is that, particularly long-term care costs that we think about normally are not new costs. All these long-term care programs have done is essentially monetize something that society itself was already bearing. So if it wasn't the government or some insurance scheme, it was the family or somebody else who was incurring the cost, but it just didn't have any dollar value. And so we need to have a bit more kind of a holistic view. Just because it's monetized doesn't mean it's necessarily a new cost, and we still have to think about the overall social burden. And it's not entirely clear that if you take that perspective, that all home-based solutions are necessarily less burdensome for society. Then I'm certainly, just on the data question, obviously I'm a researcher, I always want more data. I'll pass that, but I think that I would agree. Just on the obesity issue, just to get back on that. The problem about obesity, and I think this issue of yes, and I agree, it's an issue of fundamental evolutionary biology. We're a species who has been evolved not only for millions of years, but our ancestors were evolved for millions of years to ensure that we had enough energy and enough energy stores to be able to survive and reproduce, right? That's what evolution has done. And we faced the paradox of modern development. Modern development does two things. It reduces the need for calories. I mean, whether we like it or not, that's a good thing. I mean, we don't need to do so much physical work to survive. We don't have to go and hunt an animal, right, or kill the crocodile before it kills us, right? So that's the reality. I mean, that's a good thing. At the same time, and this is also a good thing, it's made food, calories, much cheaper in relative terms than it has ever been in the past 2 million years for us. That's why we're getting bigger, okay? Now, what do we do about it? I mean, I'll share two things with you. One fact. Developed countries have known that obesity is a problem. I mean, let's be honest. Public health physicians known this for decades, almost as long as tobacco. There's only one demographic in the OECD region which has not seen an increase in obesity. Just one. Japanese women. Not even Japanese men have failed to avoid this problem. I guess in Korea, Korean men and women are getting more obese, right? It's not that we don't know. We haven't been able to do anything about it. It's very sobering that we haven't been able to succeed at the population level. Now, why? I'll tell you, I've been trying to lose weight. Now, you can't tell me that I don't know enough about obesity. I'm a physician. I have a PhD in public health. I work on the problems of NCDs and aging and whatever. I know fully well. I know the research. It is very, very hard. And it's very sobering. What it made me realize, obesity is fundamental, and it's due to our evolutionary biology. It's a problem of our brain. It's a brain disease. Right? That's why it's so hard for humans to lose weight when they have lots of food provided to them. Right? Because your body, your brain, overrides all sorts of hormonal influences and everything else to put your weight up. It's not enough to give people information and education, right? And so I think we need to be cognizant of that fact, and cognizant of that we really have, I think at this point, as scientists, as economists, as public health people, we really have right now no adequate tool intervention that works. And it's not about, we shouldn't be blaming people. I mean, saying people do these things, bad behavior, lifestyle choices. The reality is we have no way of helping individuals keep their weight down in the modern environment and lose weight effectively in a sustained manner. And we have no way of doing this at population scale. So I think we should be realistic. It's something we have to figure out. And I don't have the answer right now. But it should be really a big priority for future research, which means public money.
Thanks, Ravi. Could we briefly have your feedback as well about some of the questions?
I heard about a specialist as we propose that we should have more GP in terms of primary care, and relate to the professional organization and unethical things. I think that this is should be the one that we can discuss more, but we need a lot of time. No? It depends on each country to plan for that one, I think. Yeah.
Thank you for your responses. I will just add a couple of things in response to some of the comments, questions made. I think for the home-based care models, HelpAge Korea has been doing a lot of work, and they would be able to provide a lot of insights on what is the costing, and they have also been able to influence some of the neighboring governments for their application part. So that's one source of information which could be handy to understand that. And to the points regarding the lifestyle, the health behavior, as well as the importance of data collection, I believe that the HelpAge network partners in Asia are doing a lot of work on that. An example would be Scope in Singapore, which is focusing on lifestyle issues and health-seeking behaviors, as well as some of the data collection that HelpAge partners are doing in South Asia to improve the data collection capacities. So those will be the useful pieces of information. I did see some more hands, but okay, I'll take one last question, and please keep it brief. Yeah.
And elderly care, only if these financial resources are not enough, we need to build the physical resources, and in order to meet those physical resource requirements, I think the social capital can contribute significantly. So I would like to know from Ravi, because Ravi has been working on these, what contribution can the social capital make, and if we have any evidences from these countries where he is working. Thank you.
As well as you could make your concluding observations, and then followed by Sunman and Vipada.
Just to clarify, social capital, you mean the kind of relationships between people? Yeah. Okay. I think that's important, but we also need to know, I mean, as Sunman said, in Korea and Japan, the issue of, family structure is changing. People are getting busier. They have other things to do. Women need to work. I mean, they want to work. So, all these other things are going on. So I think we need to be cognizant of social change. And then the other thing I would just say about social capital, I think one of the use of public money for financing social policy, whether it's health or not, to me is the ultimate manifestation of social capital, right? So it is our failure to recognize our own need for solidarity, which is really embedded in the whole idea of social capital, that we often have a lot of the problems. So I think I would just remind you of that, and happy to talk about that later. I think just to conclude, we covered a lot. These are problems. At the end of the day, aging, yes, we should think of it as it's not really a problem. Aging is a good thing, right? We all live longer, and we just have to figure out, in this wonderful era where we all live longer and maybe many of us can live to be 100, how do we cope with that, and how do we change the way we organize ourselves as humans to be able to cope with those issues? I think that's really the challenge. And I think we should not necessarily see this as necessarily a problem, although we clearly do have to figure things out in the next generation or so.
Okay, I agree that elderly or aging is an opportunity for all of us to help each other to take care of the elderly, to be happily elderly and live longer. And I think that this is a very great opportunity to discuss among us. And I think that money may not be everything that can serve the people. I think that how to make them live happily, this is the most important thing. And they may live with the family or by their own. Yeah, that is my point.
Well, in kind of a take-home message for you, I think first, in terms of the potential pressure of aging on the health system, on the healthcare expenditure financing, I think it is not just we don't have to be too much worried or obsessed with aging issues, because there are so many other factors, and we can cope with it, for example, by health aging and effective management of end-of-life management and care system. Second, UHC should be a fundamental solution and a policy priority okay, for the health of the older people. And then for UHC, mandatory public sector financing should be the ideal pathway to achieve UHC. Third, coordination of healthcare and long-term care system is very essential. Okay? Otherwise, without this holistic approach, we cannot improve the health and happiness and welfare of all people. Finally, it's not just efficiency, but equity. Because in many countries, the evidence shows that equity issues or inequality gap tends to be increasing or bigger for all the population. So we should pay attention to these very important inequality issues for all the population. Thanks.
Thank you. I think it has been a very enriching 90 minutes of this topic, and wonderful thoughts from the panelists, as well as questions from all of you. My concluding messages will be, in addition to what the panelists have said, that universal healthcare is definitely the solution, and there will be local context, local conditions in different countries. Everything is not going to be possible everywhere, so every country will have to deal with its own problems, with its own resources, with its own capacities, but they have to have a UHC in the country, which is going to be important for the financial implications of healthcare costs. I completely agree that lifestyle, health-seeking behaviors, education are very important parts of care, and therefore the community care components become even more important. I think it was said in the presentation that medical care is not everything, which is very right, as well as the comment on social capital beyond the financial resources. So it has to be looked at the whole picture in this holistic way, where you have lifestyle, you have health education, you have health-seeking behaviors, and of course diseases which are linked with lifestyle, like obesity, which we have talked about, and then identifying those risk factors and focusing with a new approach, with a reoriented kind of health services design. And data collection is one area which is an area of gap in many countries with differing capacities, varying infrastructure and facilities. So that's one area on which a lot of work is required. What I can say is that some good work is happening within the HelpAge network in different countries. So those are the initiatives which could be looked at, could probably be replicated in other countries, other environments. So this discussion is very timely because we just heard in the morning some of the people who were here in this room from John Beard, the WHO report on aging, and that report is now going to be taken for follow-up action by countries, by national governments, to have more feasible, more realistic action plans. And of course, financial implications are going to be an important part of that action plan. So good policies are prerequisites for good work, for good implementation. So this is probably a good time to have thinking on that side, to make sure that as the demographic changes happen, we have cost-efficient and cost-effective measures in place in different Asian countries on healthy aging. So I thank you all a lot for being in this session. I thank all the panelists for your presentations, for your time. Could you please join me in giving a round of applause to them, and thank you very much.